Welcome to the Derm Vet podcast, where pet skin is always in. I'm Dr. Ashley Bourgeois, board-certified veterinary dermatologist, skin nerd, and your go-to guide for everything itchy, smelly, and inflamed. I'm here to take the itch out of your day and make derm more fun than frustrating. Grab your microscope and let's focus in. Well, welcome to another episode of the Derm Vet podcast. I actually just returned from a little tour of Western Canada, speaking all about itchy dogs and ways to manage them. And it was just a really wonderful experience. So if you were anyone who I got to see in Western Canada, thank you for that. And in true mom fashion, I got off a plane and I am recording the podcast before I have to run and go get the kiddos. And that is just the real life messiness of being a veterinary mom. But I always love doing grab bag episodes. I just think they're so fun to be able to see what questions you guys have, see what directions we need to go about certain topics. So this week's grab bag episode of the podcast, I asked you to give me your questions about autoimmune diseases. It was mostly focused on dogs, but I got a couple little cat comments in there, which I'm happy to oblige. So we're going to jump into 6 different questions that you guys had about autoimmune diseases in dogs and a little bit of cat. Question number 1. I struggle with a good complete treatment plan with SLO, which is symmetrical leukoid onychodystrophy, and sebaceous adenitis. Can you help? Of course. So let's break these down disease by disease. So let's start with the first one. You'll often hear us call it SLO, and that's SLO, and that stands for symmetrical leukoid onychodystrophy. And it's just like it sounds in medical terms. Symmetrical, it's usually multiple nails, claws that are affected. Leukoid is the band of inflammation that we see with lupus-like diseases, same with DLE. Then onychodystrophy is obviously the medical term for just messed up nails, messed up claws. So with that disease process, things have changed a little bit in how we diagnose it. For the most part, now most of us just consider it a clinical diagnosis. Historically, you will see in the textbooks that you can amputate the P3 of that digit that's affected, or multiple digits that are affected, because you have to send in that whole P3 of that digit as an amputation to actually send the claw in. The problem with that is the decalcification for that kind of bone and claw it really makes it hard for pathologists to read. So most people I know do not recommend actually removing, amputating that toe at this point in time. It's a clinical diagnosis we make. Usually what we see is a dog will have one claw lift, and then they'll think it's traumatic. And then all of a sudden, throughout time, more and more claws will lift. And that essentially gets us suspicious that there could be an autoimmune process, because it's probably not very common for a dog to injure multiple toes on multiple paws at different times. So then we usually consider it a clinical diagnosis. So usually these claws are kind of lifted up, and they're really uncomfortable because as they lift, that proximal portion of that claw is kind of pressing down on that claw fold, and that creates a lot of pain and discomfort. So when we see these dogs come in, we see those nails lifted, then we can feel pretty good about at least a starting diagnosis of SLO. So then what do we do? So if there are claws that are loose or kind of lifting up, it is really helpful to provide comfort by giving them really heavy sedation or general anesthesia and actually do what we call avulsion, which is just pulling off that claw. I know that sounds really rough. It may be painful to do, but I have had dogs literally with multiple claws lifting and uncomfortable within my exam room. I have sedated them, removed these claws, and I've had them running out the door, because that claw, it just creates so much pressure and discomfort when it's pressing on like that, and they can lose them on their own, but sometimes you'll get stubborn ones that really hang on. The other thing I forewarn owners about is that if we start to have some claws lifting, even when we start treatment, it's not abnormal for them to have multiple claws still kind of go through that process and fall off. And kind of once we get that steady state where either all of them have fallen off at one point in time, or at least a good chunk of them and they're stable, then we watch for the flares in the future to know if that treatment plan's working. So it's not abnormal for them to lose multiple claws once you start diagnosing them, because that inflammatory lupoid inflammation's kind of already happened. And we're just waiting for the end result of it, right? It kind of cuts off circulation, it splits that nail from the quick, and that's where we get this disease process. So how do we treat it? Very similar to what we see with a lot of other autoimmune diseases. So you can use JAK inhibitors off-label. So either Apoquel or Zenrelia potentially could decrease inflammation. So if I have a dog who concurrently has, say, allergies and SLO, like I go through the history and they have been a paw lick or chew or they've had ear infections, sometimes I personally reach for a JAK inhibitor as a treatment plan just to see if I can control allergies, the more abrupt allergic itch in that disease at the same time. Yes, of course, you can use things like steroids, cyclosporin. Again, if they have a history of allergies, cyclosporin potentially could treat both of those things as well. I personally also like to use pentoxifylline. Pentoxifylline, this isn't vasculitis, it's different, but you're still kind of giving those vasculitic properties. And sometimes that's my other differential, right? If it's not SLO, it could be vasculitis, because with vasculitis, they can also have their claws fall off. So to me, it's a really benign medication that has a different mechanism of action, making those red blood cells a bit more flexible. And I mean, the only side effect we potentially see is very rare vomiting, which most cases don't do. So I will oftentimes use pentoxifylline with these cases concurrently with something else, depending on the disease process. And then, of course, there's always the traditional doxycycline or tetracycline and niacinamide. So moving on to sebaceous adenitis. Sebaceous adenitis is a bit different than the other autoimmune diseases we see. There's not a lot of systemic options that we get a lot of proof with as far as being helpful and effective. So this disease is predominantly seen in standard poodles and standard poodle mixes. So yes, the labradoodles, the bernedoodles, the golden doodles potentially are predisposed because they are a mix of a doodle. But we can see this in other breeds as well that are predisposed, like Akitas. Vizslas can get a specific form of sebaceous adenitis as well. And really, the diagnosis on this is based on biopsy, and you have to be really greedy with your biopsy results, and you really want to make sure these go to a dermatopathologist, because it's great if you have a lot of inflammation around the sebaceous glands, but you can also get end-stage sebaceous adenitis, which means all the sebaceous glands are just gone. And that's a really difficult disease to manage, but it often can be missed by pathologists if they're not looking for it, because, it's easy just to kind of not recognize the sebaceous glands aren't there if you don't have a lot of inflammation and other stuff that's also present. So if you have a dog who's just kind of getting an unkempt coat, scaling, they get something that we call follicular casting, which is pretty specific to this. We usually see it on their dorsum. We can see it on the pinna. You can see it on the tail. If you just kind of get this hair loss that's unexplained, you do hormonal testing like thyroid, and that's pretty normal, especially if they're one of those breeds. I would biopsy, and I will take like 5 different sites. I'll get different representations of the lesions just to give my pathologist the best chance possible that they get the diagnosis, because it can be a tough one. And then a lot of this comes down to skin barrier repair. So I use a lot of the seborrheic topicals. It's like BioSeb shampoo by Nexmune, Duxo S3 Seb. I like those as options. I will use spot-ons like the Dermacent spot-ons. You can even see protocols for propylene glycol, alpha carry oil. You can try skin supportive diets. So really you're trying all those basic skin supportive things. You're basically trying to act like the sebaceous glands for that pet. The systemic medication that we have the best literature support of is cyclosporin. So there is some proof that in some cases, cyclosporin can actually help to decrease that inflammation and regenerate or just allow the sebaceous glands to come back. So I will often still put them on cyclosporin, again, especially if they have a history of something like allergies, but it's super important for owners to notice it's a really time-involved disease to manage, because you are basically trying to do all the skin supportive stuff just to kind of act like the sebaceous glands that they're having an issue with. So that is a great question in a disease process that's a little different. Question number 2, it's kind of a general one. So when steroids show side effects, which drug protocols do you use for autoimmune diseases? And of course, this very much varies on what type of autoimmune disease you're managing, right? That's why biopsy is so important. Yes, we use steroids a lot in autoimmune diseases, but there are certain diseases like what I mentioned with sebaceous adenitis, where we do get a little bit more of a guidance on which, autoimmune drug we should consider using, or we can give a better prognosis for that owner or know what to have them watch out for if things aren't working well. So if I just do kind of a generic statement for this, mostly focusing on dogs, then it's a lot of the ones we already mentioned. So cyclosporin, you can find many studies out there, especially with Apoquel because it's been around longer, but for using JAK inhibitors off-label, of course, it's an off-label use to manage autoimmune disease in dogs, whether on their own or potentially as a steroid-sparing agent. So maybe you can't completely get off steroids, but you can tremendously lower the dose of it. Then, of course, you get into the meds we've had for a very long time. Azathioprine. It can be a great medication for autoimmune diseases, but it's not fast and it has a lot of potential side effects. So we have to monitor lab work very closely on them, at least for the first few months. And that can be daunting for owners, but it's certainly an option. We're watching for things like hepatopathy and we're watching for things like bone marrow suppression. Mycophenolate tends to be fairly well tolerated. Again, can take some time to work, but you can get some stomach upset. And we certainly still watch things like the liver. And then going back to the more benign protocols like doxycycline, niacinamide, tetracycline niacinamide, depending on which one's more available for you. I am a bit thoughtful of not just jumping on this with every case, just with the thought of long-term antibiotic usage, but there are certainly cases where this can be really helpful. We often see people use this in lupoid diseases like discoid lupus erythematosus. And then you can use this in dogs, but an option that we have in cats, since we're so limited on cats, I've probably seen this used in cats more for skin disease, is Leukeran. I don't use it a ton, but I have had a couple Pemphigus Foliaceus cats where it's been extremely helpful. And then, of course, it depends on certain specific things, right? Like pentoxifylline for vasculitic diseases could be a good treatment option. Certainly then you get into like all the supplements and more benign things like high dose fatty acids, vitamin E, things of that nature, depending on the disease that you're treating. So those are just kind of some general options that we see used. Question number 3, what to do when owners can't biopsy the case? This is a great question because there's always going to be situations that are not perfect, right? Whether it is that they have a lot of comorbidities and it's not safe to have them anesthetized or sedated, whether there's just cost concerns and we can't do it. So one, I will just use the other tools I have that maybe are less invasive or less expensive. So cytology is a huge one, right? We want to just make sure like, hey, it could look really bad, but if you see a lot of cocci, let's treat that and kind of make sure it's just not a really bad pyoderma. Because I have had cases where I have to treat the pyoderma first. Like, I don't actually know if it's autoimmune or allergic because they're so full of infection that I can't tell, right? Making sure your skin scrape because demodicosis could potentially look like something like an autoimmune disease. Dermatophyte culture. So there's other tools that you should just be making sure you rule out other causes. But let's say you've done that and you feel really confident something's going on autoimmune. Then you really have to just make sure the owners know, we are kind of blindly treating here. We don't exactly know what we're treating. I've had situations I've had to do this in dogs and cats, and they just kind of understand that assumption and that risk. We will usually stick to things like either starting with low-dose steroids because there's such a broad range of diseases that it manages. Then we can often just see what results we get with that. Potentially cyclosporin, again, because it's just a broad range of things that it manages. But then I'm also using my brain, right? Like distribution, how much of the body's affected. It doesn't mean I know for sure. That's why I biopsy, but I can at least have a suspicion. Okay, like this could be DLE or Pemphigus foliaceus. And the owner just kind of understands that we're treating the best that we can. And then I give them other signs to watch for. So I want you watching for other portions of the body being affected. If this depigmented area becomes more ulcerative in the future, then that's another thing that they watch for. So you just do the best you can. And the other thing I want to mention is document, right? You want to write down the decline biopsy. So if someone else gets that case, they're not wondering why you didn't do it, and make sure it's in the discharge too. Like, as we discussed, biopsy would be the gold standard to diagnosing your pet's disease. Unfortunately, we can't do that, or you have declined this today. So we are going to start treatment the best that we can. So I think it's super important to document these cases so that we are all aware as clinicians, but the owner is aware too. And there's no shame in that. We don't practice in a perfect world, but we need to document it so that everyone's on the same page and knows. Question number 4. What are the different clinical signs you can see with Pemphigus foliaceus in dogs versus cats? So this is where cats came into play a little bit more again. So the big thing, so when we think about Pemphigus foliaceus in dogs, typically we get like adherent honey-colored crusting. We tend to see it a lot on the trunk. It can affect anywhere. Obviously, the nasal planum can be affected, so you'll get depigmentation, swelling, potentially ulceration, crusting, paw pads. So if you see paw pads on a dog that are really thick and crusted, that's not normal for allergies. So then I would be thinking about something like Pemphigus foliaceus, among other things that it can be. And those would be probably the main ones: honey color crusting, seeing paw pads affected, truncal lesions, looking under the microscope and seeing lots of neutrophils, but not a lot of infection. In cats, we can get some of those things to be true too. So I have seen a cat with scaly paw pads before, but I've seen like one ever. It was like really crusted scaly paw pads in a cat. I've seen tons in dogs. So that's not quite as common, but possible. I'd say that obviously the big ones we always talk about in cats are the claw folds. So those cheesy claw folds, if there's purulent debris, if there's swelling of the claw folds in cats, that is very highly suspicious of Pemphigus foliaceus, which is quite different than what we see in dogs. The other two places, especially cats like to get lesions with Pemphigus foliaceus, the pinna. So if you've got really thick crusting on the concave convex portion of the pinna, that can also happen in dogs, but we definitely see that in cats. And then actually around the mammary glands, around the nipples of cats is another unique area that they tend to show it to us. But I have had cats with nasal planum disease and facial crusting as well. So some similarities, but also some pretty big differences we want to recognize. Question number 5. What are general signs that a dog or cat has an autoimmune disease versus something like allergies? Another really good general question. I like to say not every itchy dog, not every crusty dog is allergies. So what are some of the main things I think of? A lot of crusting and not a lot of infection underneath the microscope. So remember that, of course, pyoderma can cause crusting, but if you don't have cocci rods underneath the microscope, but a lot of neutrophils or abnormal cells, I would be starting to think about autoimmune being a potential option. So that would be a big one. Areas of the body that are affected. So the nasal planum being really swollen, mucous membranes in general being depigmented, crusty, or swollen. That's not typical for us to see with allergies. So I'd really have something like an autoimmune disease on your list. Potentially if they're not pruritic, we can see allergic dogs that just get infection and are not really itchy. And autoimmune diseases can be itchy, but if you have a really crusted dog with all of these lesions and you're not seeing them be very itchy, because pyoderma and allergies usually are itchy, then I would have it on my radar as well. But I would say the big thing would be areas of the body that you don't expect and abnormal lesions like ulcers, depigmentation, crusting. And then the last question I have in the grab bag today: how do you differentiate between DLE and Pemphigus foliaceus in a dog? This is a good one because those are the two most common autoimmune diseases that we see in dogs, and you're probably going to see in your general practice. So most of the time, discoid lupus erythematosus, I'd say more often than not, is really focused on the nasal planum. So you get crusting, ulcers, depigmentation, loss of the cobblestone appearance. Those are very classic signs of DLE. Pemphigus foliaceus can just affect the nasal planum. That's why we try to biopsy these cases. But usually we see other areas affected. So they got nasal planum being depigmented, ulcerative, crusty, but also like the bridge of their nose, the trunk, the paw pads, all the places we mentioned before also have some sort of lesion that's suspicious of an autoimmune disease. Now, the flip side, DLE can spread. So I have seen dogs with DLE where it's on their nasal planum, plus it goes up their muzzle a little bit, or it can go like around their eyes. I even had one weird case where it was the nasal planum and had part of the pinna. So you can see other lesions, but it's just not as common compared to what we see with dogs that have Pemphigus foliaceus. I would also say that I tend to see more systemic signs with Pemphigus foliaceus over discoid lupus. So it's not abnormal for me to have a dog who's febrile, who's really uncomfortable, painful with Pemphigus foliaceus. They can, of course, be uncomfortable with DLE, but I don't tend to see it quite to that degree. Now, many of the treatment options are going to be very similar to what we talked about before, but it just gives us a better idea, one, of like prognosis, knowing exactly what we're dealing with. Also, for owners to watch out for other lesions that could be happening at home once we actually know what we're treating. So DLE tends to be more focal, more the nasal planum and nothing else. Pemphigus foliaceus in dogs we see to have other lesions like the honey-colored crusting. But again, I have been fooled before, so that's why biopsy multiple sites from the nasal planum, if you have a nasal planum disease, can be really important. We're not even bridging to the fact, since we're talking about autoimmune diseases today, that these diseases also can look just like skin lymphoma. So that's why biopsy, if we can get owners to that point, if they can save up to biopsy, is so important, because clearly my treatment options, my prognosis for cutaneous lymphoma is much different than a discoid lupus case. So with a lot of these autoimmune diseases, we can see other bad internal diseases, like hepatocutaneous syndrome can cause crusted paw pads, so that's an important differential. Lymphoma can do whatever it wants, so you certainly can have autoimmune cases that actually biopsy and come back, or you think they're autoimmune, you biopsy, they come back as neoplastic. So that is why we're such big advocates for cytology to make sure infection's clear. If the lesions are still present, then biopsy is the gold standard, getting multiple sites, making sure a dermatopathologist reads them, because it is tricky. And even as a specialist, I am often surprised or fooled by my biopsy results, which is why we do it. So I hope that is a benefit to you. You guys had great questions, as you always do. If you have any particular topics you would like covered or guests to come on the podcast, which obviously, if you're not watching on YouTube, I would love to have you watch it on YouTube, because I am putting clinical pictures up throughout these episodes, and there's some good ones on this episode. If you're on YouTube, thank you. But feel free to reach out. Let me know what you want to see so I can keep giving content that you find valuable in your everyday practice.